Hello friends. Okay, let us learn a new topic today. In the last lecture, we have completed about urethral rupture. So, continuation with that. Now, I would like to start with urethral stricture. Right? So, first let us start with urethral stricture so that we can go with the other small topics later. So, what is a urethral stricture? There is urethrum. This is the bladder. So, this is the prostatic urethra, and then membranous urethra, and then this one. What is this called? Bulbar and penile urethra. Right? So, urethral stricture is formation of some stricture somewhere in the urethra. Right? So, this is urethral stricture. So, there are many classifications for this urethral stricture. So, let us learn one by one clearly. Okay? So, first, classifications. First, based on etiology. Number 1, congenital, which occurs since birth. Inflammatory, which is due to some infections. So, what infections are majorly responsible? One is post-gonococcal. This is the most commonest, that is approximately 70% of strictures are due to gonococci. That is, after gonococcal infection, there is possibility of post-gonococcal strictures, and then tuberculosis and other infections. So, these are inflammatory, and then traumatic include bulbar, bulbous type, and membranous. And then the fourth one is post-instrumental. It may occur after instrument because of some injury to the urethra. Right? Which instruments do we use? We generally use catheter. Sometimes we keep a dilator, or cystoscope can be kept for viewing the bladder and urethra. Okay? And finally, post-operative, after operations, after surgeries. Which surgeries? The most common surgery is prostate surgery. Okay? And the other is ureterostomy. So, these are the major etiological classification of urethral stricture, which classifies it into congenital, inflammatory, traumatic, post-instrumental, and post-operative. Now, coming to the second classification of stricture urethra, which is classification 2, where the urethral stricture is divided into two types, which is proximal and the other one is distal. In proximal, it is common in bulbous urethra. Okay, this is for about 70%. Distal, it is in congenital or traumatic, are more common in distal strictures. Now coming to the third classification. It can be two types. One is permeable stricture, that is allows urine to pass through. And then impermeable stricture. And finally, classification 4, which is passable stricture, where catheter can be passed The other one is impassable stricture, where catheter cannot be passed. Then the next classification 5, which is single and or multiple. And classification 6 include whether the stricture is present at the floor or at the roof. So this roof, it is most common. So these are the different classifications of stricture. So generally the etiological classification is the most important. So now let us learn about the clinical features of stricture urethra. I will deal about the gonococcal stricture briefly later at the end. So first let us learn about the clinical features. Right. So now this is the bladder. And then this is the prostatic urethra, membranous urethra, bulbar urethra, and then penile urethra. Okay. Now, so this is the classification. So there is some stricture here. Just think that there is stricture here. So what happens? If the stricture is able to pass urine, even then there is poor urine stream. Think that even urine, it is allowing to pass urine. Even it is passing urine, there is poor urine stream. There is forking and spraying of urine stream. Because of stricture, there is incomplete emptying. So let me write here itself because. And then there is frequency. There is even dysuria, difficulty in passing urine. And then retention of urine. Then there may be pain, burning micturition, and even suprapubic tenderness can be there. There is thickening and button-like feeling in bulbar urethra. So basically these are the major clinical features. I'm sorry. So these are the major clinical features which are seen in stricture urethra. Right? So what are the investigations that you advise the person to undergo? Investigations. First, you ask them to undergo urine microscopy and culture. Okay. Then blood urea nitrogen and creatinine to know the renal function, that is renal function tests. Okay, now coming to structural abnormalities, IVU, intravenous ureterogram is done to see if there is hydronephrosis of the kidney and also the function of the kidney. And then ultrasound abdomen to see if there are any other strictures and to point out the exact stricture. And X-ray pelvis to see the old fracture, for old fracture if present, to know about the urethral injuries. And then ascending ureterogram. This is to know the site, type, extent of passage. Okay, ascending ureterogram can be done. And then urodynamic studies, which are pressure flow studies, can also be done, to exclude them also. And urethroscopy can be done. Okay, so these are the major investigations which are done for stricture urethra. Now, what are the complications of stricture urethra? The major complications of stricture urethra is retention of urine, number 1. Then, urethral diverticulum. Because of increased urine, there is a chance of urethral diverticulum. And whenever there is infection, there is a chance of periurethral abscess. And when this abscess ruptures, if infection, periurethral abscess, if ruptures, then there is fistula formation, that is urethral fistula. Okay. Then because of retention, there is bilateral hydronephrosis, and because of retention there is stone formation. Okay, and because of retention and this one hydronephrosis, there is renal failure. Okay, and finally the person strains a lot to micturate, so straining causes hernia, hemorrhoids, and sometimes even rectal prolapse. Right, so these are the major complications which are seen in stricture urethra. So let us learn about the treatment aspects about stricture urethra. Okay, so what is the treatment that you give for stricture urethra? Number 1, you give intermittent dilatation. So, if this is the wall and if this is the stricture, so what you do is you will pass dilators, thin dilators. First you will pass, there should be gradual dilatation. First thin dilators are passed, and then thicker. You will have to increase the size of the dilators. Okay, this is done in OT under aseptic precautions. So, should avoid forceful dilatation. Forceful dilatation is avoided. So, the dilatation is done. Frequency, if you wanted to know frequency of dilatation, you'll have to do once a week for 1 month, and then once a month for 1 year, and then at least once a year. That is on his first birthday. On his birthday every year, you will ask him to do a dilatation once. So this is intermittent dilatation. So what are the dilators used for intermittent dilatation? Dilators used. There are many dilators, among them Lister's dilator is the one which is used. And then we can also use Clatton's dilator. So these are the names, just remember the names, that's it. Clatton's dilator, and then filiform Baugh's. Okay, so what are the complications of dilator? First, infection and bleeding may occur. Why? Because these dilators may cause trauma. That trauma leads to infection and bleeding, and there may be false passage formation, and sometimes there may be rupture leading to fistula formation. And then the second treatment which can be given is visual internal cystoscopic urethrotomy or stricturotomy. So here first we use a cystoscope. So this is the bladder and then prostate. Okay, first we will pass a cystoscope. So this is the stricture. Okay, first you will pass a cystoscope. Okay, then after passing a cystoscope, then visualize the stricture, and then this is the stricture, right? Then you will have to cut it at 12 o'clock position. First pass a cystoscope and then cut the stricture at 12 o'clock position. At 12 o'clock position, just cut the stricture until it bleeds. Then pass Foley's and keep it for 48 hours for 2 days. Okay, and this heals. So this is visual internal cystoscopic urethrotomy or stricturotomy, where you will pass a cystoscope. This is the cystoscope, and then you visualize this stricture, and you will cut the stricture at 12 o'clock until it bleeds. Pass the Foley's catheter and then keep it for 48 hours. So this is what is done for visual internal cystoscopic urethrotomy. By seeing, you are cutting the urethra. Then the third treatment is external urethrotomy. This is an open method. Now it is not used because we do cystoscopic urethrotomy more popular, but it is used to be done long back. So this surgery is also called as wheelhouse's operation. Okay, next the fourth one is urethroplasty. Okay, in this what do we do? This is the bladder. Okay, so this is the stricture. What we do is, we will now remove the stricture. Okay, we have removed the stricture. This is what is there after removal. And then we use a profusal skin or scrotal skin. To reconstruct the ureter. So this is profusal skin is used, and this was used to reconstruct the ureter. So first we have resected the stricture, and then use profuse or scrotal skin to reconstruct the urethra. So this is urethroplasty. So what are the problems in urethroplasty? So in that, number 1, infection may occur. Next, necrosis of skin flap. Next, there may be leak and fistula formation. There may be restenosis, right? The skin flap which is kept, that may undergo necrosis because we are doing it through cystoscopy and other things. There may be infection through open technique. There is a chance of infection for every operation, and then whenever this anastomosis is not done properly, in that cases there may be leak, and sometimes there may be fistula formation, and sometimes recurrence of the disease may occur. So what do you call this as urethroplasty has? This is called as Johnson's urethroplasty. This is the other name for urethroplasty. So this is the treatment option. These are the treatment options which are available for urethral stricture. Thank you guys for watching my lecture. In my next class, I would deal about hypospadias and epispadias. So thank you for watching my videos. If you have any doubt, just comment it in the comment section. I will try to answer them. If you feel something is inadequate, or if you want some topic in advance, you can even then comment it in the comment section. Thank you guys for watching my video. Thank you.